The Washington Manual of Surgery podcast is based on the 9th edition of the best-selling Washington Manual of Surgery.
This podcast is meant to condense key topics from our manual into bite-sized episodes for your convenience. Now, on to this installment of the Washington Manual of Surgery podcast.
Hello, everyone, and welcome back to the Washington Manual of Surgery podcast. We bring you everything you need to know about high-yield general surgery topics built for your just-in-time learning. My name is Catherine Zivanov. I'm a general surgery resident, and I'll be your host for this episode. We are thrilled to have Dr. William Chapman Sr. back for part 2 of our discussion on surgical diseases of the liver.
Thanks, Catherine. It's great to be back for part 2 of this podcast.
Dr. Chapman is an abdominal transplant and hepatobiliary surgeon here at Washington University in St. Louis, where he serves as the Eugene M. Bricker Endowed Chair of Surgery, the section chief of the Division of General Surgery, and the surgical director of the Transplant Center. Thanks for joining us today, Dr. Chapman. On today's episode, we'll cover malignant liver diseases. Let's jump right in with a case scenario. A 55-year-old man presents to your clinic with vague abdominal pain for several months, along with 15-pound weight loss. His past medical history is notable for hepatitis C infection that was treated and cleared. His labs are notable for a serum alpha-fetoprotein of 30, a normal CEA and CA19-9, mildly elevated liver function tests, an INR of 1.5, a bilirubin of 1.2, a sodium of 140, and a creatinine of 1.2, with a combined MELD of 13. Triple-phase MRI demonstrates a 4.3 centimeter LIRADS-5 lesion in segment 3, with rapid hyperenhancement on arterial phase and rapid washout on portal venous phase, consistent with a diagnosis of hepatocellular carcinoma. His scan also demonstrates a 1.5 centimeter suspicious lesion in segment 4, and it does not demonstrate any ascites. What factors do you consider when determining management strategies for patients with hepatocellular carcinoma?
Catherine, this is a great case for discussion. HCC is the most common primary liver malignancy, making up about 80% of all primary liver malignancies. And there are lots of treatment options, which is good depending on the situation, but also can be confusing when you're thinking about which patients do get consideration for resection versus transplantation versus regional therapy. Now, management strategies depend on the patient's performance status, their background liver function, which is reflected pretty well in their MELD score, and we'll talk about that in a few minutes, and also on the extent of HCC. So the number and size of tumors, and of course, whether or not there's extrahepatic spread. Let's talk briefly about the MELD scoring system. So the MELD score stands for Model for End-Stage Liver Disease, and this is a scoring system based on 3 objective variables: the serum creatinine, the serum bilirubin, and the INR. There is a more recent variation of the MELD score, which is called MELD sodium, which also factors in the serum sodium value. Now, these objective laboratory studies are used to generate a score using a logarithmic formula. The score ranges from 7 to 40. This is not a scoring system that you can calculate in your head. You can find the formula, just do a Google search and you'll find it and can get the score. And you'll have an idea of what that score might be as you become more experienced. But in general, 7 to 40, 7's normal, 40's very severe liver decompensation. So we use this scoring system in patients that have known liver disease. So we think about standard hepatic resection in patients that have a normal background liver. And again, this is about 20% of all patients with HCC, normal background liver, and a solitary liver tumor. Then we would think about standard hepatic resection. This is a minority of patients that have HCC. there are other types of scoring systems that can be considered, like the Childs-Pugh score, which I'm not going to really get into. But these are factors that can help to decide who has very well compensated liver disease versus more decompensated liver disease. In general, hepatic resection should not be performed in patients with a MELD score above about 10 or 11, and certainly not in the presence of portal hypertension. Don't think about doing a standard hepatic resection in that setting, or I would also add when there's multifocal disease, unless the patient has no consideration for transplantation. So the patient may have other factors, including their social status, that won't allow them to have a transplant. Then maybe in the patient with some degree of hepatic fibrosis or 2 tumors, you might think about resection. So I've told you the MELD scoring system. Now, in patients that have HCC within certain parameters, they can be considered for and will be considered for receiving MELD exception points. So MELD is used for organ allocation in the United States and pretty much around the world. So patients are placed on the transplant waiting list based on their MELD score. So patients that have well-compensated liver disease and HCC, they may have a normal MELD score 10. Well, they'll never come up for a transplant. So what's been implemented is an exception scoring system. So for patients that have early stage liver disease, and that would be patients that fall within Milan criteria, they would get exception points to give them a higher MELD score and potentially come up for a transplant. What are the scoring systems? So what about Milan criteria? So this is a single tumor up to 5 centimeters in size, or 2 to 3 tumors, with the largest being 3 centimeters in size, and no evidence of vascular invasion or extrahepatic disease. Another slightly expanded system is the UCSF criteria. So this is like Milan, but a little more expanded. Single tumor up to 6.5 centimeters in size, or up to 3 tumors with none exceeding 4.5 centimeters and a total tumor diameter of less than or equal to 8 centimeters. Again, no vascular invasion or extrahepatic spread. So Milan criteria is most commonly used, but under certain conditions with well-controlled disease, patients who have tumors that fall within UCSF will be considered for exception point scoring. So this is used for consideration of transplantation, but can also be used in thinking about the MELD score, that is, and thinking about a patient who's going to be considered for standard hepatic resection. Now, when we put all this together, let's say in this case, this patient had a history of hep C. Most, even though the hep C's been clear, most believe that HCC occurs in the setting of hep C or past hep C only when there's been at least advanced fibrosis. So that background liver is not likely to be normal. That's number one. Number two, this second tumor that you mentioned, not clearly defined, not said to meet LAREDS 5 criteria, but it's got to be considered as very suspicious. So this is one of the other problems. Even if you did the left lateral section resection, which maybe this patient could tolerate without a problem, this patient's going to be at risk for developing future tumors. That's the problem. There's more than a 50% chance in this situation that the patient's going to develop additional HCCs within 5 years. So that makes standard resection not a very favored option, in my opinion.
And for this patient, would you consider doing regional therapy?
So I think for sure we would consider regional therapy. And I think a case like this, what we would typically say is this patient will require further evaluation. As a start, we would consider regional therapy, either most likely radioembolization or chemoembolization is a way to get tumor control, and that would be done right from the start. Then the patient could undergo further evaluation, and for us, a consideration would be, what about liver transplantation? If the patient was suitable, we would head the transplant route, which is not going to occur for probably 6 to 12 months subsequently, but now the tumor's controlled. If the patient was not a transplant candidate for whatever reason, then they could be considered for hepatic resection, even if they underwent regional therapy. So the regional therapy won't in any way interfere with resection.
And do you ever have patients who receive regional or systemic therapy who then get downstage to the point where they become resectable if they were initially borderline?
Now what you're kind of talking about is, what about the patient who, from a liver functional standpoint, could be a resection candidate, but their tumor's too large? Let's say they have hepatic vein involvement that would limit their ability to have resection. Could they then downstage to become resectable? Their background liver is completely compensated. There's no portal hypertension. You're not concerned about fibrosis. Yes, in that situation, regional therapy can result in downstaging to resection. Now, much more frequently, we see patients that have advanced stage HCC, no metastatic disease. It's confined to the liver. But we would say from the start, they look too advanced to be thinking about transplantation, but they downstage, they have a prolonged observation period, well-controlled disease, then we consider transplantation. And that, for us, is not infrequent. It's probably about 10 to 15% of all of our transplants.
Okay, well, that was a great overview of management considerations for HCC, particularly for patients who might be undergoing hepatic resection or transplantation. Let's move on to our final case of this liver series. A 50-year-old man is referred to your clinic after being diagnosed with stage 3 rectal cancer with 2 synchronous liver metastases confined to segment 3. He has no history of cirrhosis, hepatitis, or other liver disease and has had no prior abdominal surgeries. Could you talk us through your approach to synchronous colorectal liver metastases?
So, Catherine, this is also a great case for consideration and discussion. You know, unfortunately, 50% of patients with colorectal cancer will have hepatic metastases. And these patients need to be considered for standard hepatic resection and other therapies, other consideration. Now, synchronous colorectal metastases to the liver are found at the time the primary is found, are also, unfortunately, relatively common. What we would typically do in this setting is consider neoadjuvant chemotherapy, and with a rectal cancer, the patient's going to be considered or going to receive and going to benefit from neoadjuvant radiotherapy to the primary, chemotherapy in general, and then consideration of hepatic resection. Now, there are a lot of considerations here. So, what you describe is metastases to segment 3. Well, this patient can have a left lateral sectionectomy. This is a relatively smaller hepatic resection. We would follow the plan of a patient can have simultaneous colorectal surgery and hepatic surgery when one of the two is not a major procedure. So, major colorectal procedure and a rectal low anterior resection, I would put that in the major category. That patient can have a smaller liver resection at the same time, like a segment 3 resection. Those can be done simultaneously. What we would not want to do is a major hepatectomy, like a right hepatectomy, in combination with a difficult low anterior resection. In those cases, we would stage the approach. The views of which one do you do first, if they're going to be staged, do you do the liver resection first or the primary resection first? I think either is acceptable. Historically, the view's been resect the primary first and later resect the liver metastases, although there are certain situations where someone would resect the liver first and do the primary later.
And I think one thing you've already alluded to is the fact that the liver metastases in this case are in segment 3, which would require a relatively minor hepatic resection. For patients who are going to undergo a hepatic resection that is more involved or more major, can you talk about the concept of future liver remnant and how that factors into your operative planning?
Okay, so we can resect up to 70% of a normal liver. In other words, if the future liver remnant will be 30% or larger, it's probably okay to have a resection up to that size. But, not infrequently, if we need to do a right trisectionectomy, for example, or even occasionally a right hepatectomy, the future liver remnant may not be 30%. In that situation, we'll consider doing portal vein embolization. So the right portal vein can be embolized, usually with biologic glue. The interventional radiologists inject, and this will result in atrophy of the right side, in other words, atrophy of the side to be resected, with compensatory hypertrophy of the left. And that can usually increase the volume of the future liver remnant by up to about 10%. So you go from 25% up to maybe 35%. In situations where that doesn't get you enough, now we also consider hepatic vein embolization. So right portal vein embolization plus right hepatic vein embolization, and that'll get you even more growth. So those are things we think about to allow for safe hepatectomy.
Awesome. Well, we definitely covered a lot of information today. Thank you so much, Dr. Chapman, for being with us. We finished part 1 with benign liver disease, and then here part 2 about primary liver malignancy and liver metastases. As always, if you're looking to learn more, you can check out some of the literature we referenced in today's episode in the show notes, or you can check out our full review in the Washington Manual of Surgery.
Thank you, Catherine. It's been a real pleasure to be here today.
We are Drs. Paul Wise
and Jeff Blatnick,
senior editors of the Washington Manual of Surgery. We'd like to thank the residents and faculty of the Department of Surgery at Washington University Medicine, and we'd especially like to thank our associate editors for this edition, Drs. Catherine Caldwell, Ina Chen, Bradley Kushner, Martha Bucky McGilvray, and Jorge Zarate Rodriguez.
We hope that you enjoyed this episode of the Washington Manual of Surgery podcast. For more comprehensive information in a brief outline format, check out the print and digital version of the Washington Manual of Surgery, published by Wolters Kluwer Health and Lippincott Williams & Wilkins. Please search online for the Washington Manual of Surgery 9th edition to purchase your copy of the manual.
To learn more about the educational opportunities available in the Department of Surgery, please search General Surgery Residency at Washington University School of Medicine in St. Louis.